So I'm going to talk about CAR T-cell therapy for multiple myeloma. And I thought I'll break it up by first talking about the principles of CAR T-cell therapy, since it is a rather complicated but very elegant way of treatment. And then we can review together the clinical data and the indication for ide-cel, which is the only CAR T-cell therapy that's currently approved for multiple myeloma. And in the last part of my presentation, I want to make you aware of the toxicities that we need to expect with this treatment. So T cells are part of our normal immune system, and T cells are very good at eliminating abnormal or diseased cells. And CAR T cell technology takes advantage of the T cell function, but enhances it by adding a location device to the cells that allows the cells to more efficiently track down myeloma cells in the patient's body. And so the way this works is that blood is removed from the patient. It's a process that's called leukapheresis. And then the cells are shipped off to the company, and in the laboratory, they're manipulated to express this location device or this chimeric antigen receptor on their surface. They then undergo a growth period. The cells are being expanded. They undergo a quality check, and then they're being sent back to the institution where they're then ultimately infused back into the patient. So the patient receives their own manipulated cells back. And once the cells are infused, they then circulate in the body, track down the myeloma cells and destroy them. And in the context of that, expand and make many identical copies of themselves. So that's essentially the way CAR T-cell therapy works. So let's take a little bit of a closer look at what that location device is, or this chimeric antigen receptor that allows the T cells to find the myeloma cells more efficiently. It basically takes advantage of the T cell receptor itself, which has a signaling domain and a co-stimulatory domain that allows activation. But it introduces into the receptor a part or a piece of an antibody. And antibodies are very good at binding to surface molecules on the cells. And so basically we're taking the best of both worlds, the antibodies being able to bind and the T cell receptor being able to activate the cell and combine it into one chimeric antigen receptor that is then very efficient at binding to the antigen on the surface of the cell and destroying the cell in the second step. What is the target that these CAR T cell receptors are after? Currently, most CAR T cells in myeloma target a surface antigen on the cell that's called BCMA. That stands for B cell maturation antigen. It's a protein that is expressed on normal and malignant plasma cells and on B cells. And it can be very efficiently targeted by antibody type structures. So if you think about the different CAR T-cell products that are available for myeloma, there are many different ones. ide-cel is just the one that was approved first. Most commonly, they target BCMA, but there are CAR T-cells in development that actually have other targets other than BCMA. And there are slight differences between the different products. They can differ in the mode of targeting. So it can be one antibody molecule that's binding to just one part of the BCMA. Some other products have a second antibody molecule that may bind to another part of BCMA. So the mode of targeting can be different. The co-stimulatory domain that's contributed by the T cells can be different. There are different variants of that. And then the process of selecting the T cell that gets the CAR attached to it is also evolving. Lastly, most CAR T cell products use the patient's own cells, but I'll show you in a little bit that there are also other techniques that actually use allogeneic cells or cells from a donor. So there are different products out there. So to review the clinical data and indication of ide-cel, I wanted to first sort of set the stage by looking at what kind of response rates would we expect in the patient population that was treated in this trial. And I think it was really helpful to listen to Dr. Kaufman talk about, venetoclax and Dr. Verhees talking about melflufen, because it sort of gives you a sense for patients who have refractory disease and have relapsed multiple times, what are the chances to respond? So with, venetoclax, it may be somewhere between 40 and 60%, for melflufen somewhere around 30%. And so what was done in this particular study, which was not a trial, is that at 14 or 15 different institutions, we collected information from patients who were refractory to anti-CD38 antibody therapy. So essentially, they had received either daratumumab or isatuximab and were refractory to it. And how did those patients then respond to subsequent therapy? And you see here on the left, if the patients were not triple refractory, they had a chance of responding of somewhere around 30%, versus on the right side, if they were penta-refractory, which means that they're refractory to not only just the antibody, but also to 2 proteasome inhibitors and 2 immunomodulatory agents, then the chance of responding to any subsequent therapy goes down to around 15% or so. This is the schema for the trial that led to ide-cel's approval. It was called the KarMMa-2 study. It was a trial for patients with relapsed and refractory multiple myeloma, and they had to have received at least 3 prior regimens. And these 3 prior regimens had to include a proteasome inhibitor, an immunomodulatory agent, and an anti-CD38 antibody. They were further required to be refractory to their very last therapy. And ultimately, the patients who were enrolled there was a very, very high rate of patients being refractory to all of those agents, and being penta-refractory, meaning being refractory to all 5 agents. So about 85% of patients were triple refractory to all classes. In the trial, 3 different doses of ide-cel were tested, 150 million, 300 million, and 450 million. And the patients basically underwent the process that we reviewed before. So they were screened for the study, then underwent leukapheresis. And while the cells were being manufactured, which takes anywhere between 2 to 4 weeks, they received conditioning chemotherapy with fludarabine and Cytoxan. And then on day 0, the cells were infused. Patients stayed in the hospital for at least the first 2 weeks for observation, and had a bone marrow biopsy done at 2 weeks for an early response assessment, and then a bone marrow biopsy again at week 4 for their first official response assessment. And here are the response rates for ide-cel. So the response rates are extremely high, and we saw some beautiful responses in this trial for our patients. So you see on the left side, for patients who received 150 million cells, the overall response rate was 50%. This goes up to 69% for patients who received double the dose, so 300 million cells. And at the highest dose of 450 million cells, 81% of patients responded. And so, given that this is such a heavily pretreated population, these are really wonderful results and very, very encouraging, especially if you see that there are also deep responses. So there's about 40% of patients who actually received a complete response or even a stringent complete response. So very, very high and encouraging response rates for ide-cel. This shows the progression-free survival, and I highlight at the highest dose of 450 million cells, half of the patients still maintained their response at the 12 months mark. So the responses were not only high, but they were also durable, especially at the higher doses. Now, ide-cel, as I said before, is not the only CAR T-cell product that is being studied. It just is the only one that's been approved so far. And here's just a very selected overview of some other studies that are being performed and that also look very promising. So there's the CARTITUDE trial. This drug is called cilta-cel, that has high response rates. And the other trial, the CT-053, is a phase 1 study that's currently being conducted in China that also shows really high response rates. On the very right side is the universal trial, and I want to spend a little bit more time talking about that study because this is a study that actually uses allogeneic CAR T cells. So far, the CAR T cell production that we've talked about relies on the patient's own cells, and that comes with a couple of issues. For one, oftentimes, especially if a patient is heavily pretreated, the quality and number of T cells that we can harvest may be limited. And then, of course, the production takes time. The cells have to be shipped to the company. They have to undergo that transduction and growth and quality process. And so it takes time for us to receive the cells back. And so the advantages of an allogeneic product that comes from a healthy donor is that, first of all, the cells are easily collected because they're from a healthy donor. So they're present in higher numbers. And then once that product is made, then it can essentially be stored and frozen and can then be used what's called off the shelf rather than having to be manufactured for an individual patient, which takes time. And not only does it take less time for this product, but likely it would also decrease the cost because you could manufacture many products at the same time. There are, of course, challenges associated with using donor cells. One is that since these will not be the patient's own cells, there's always the chance of them eliciting graft versus host disease. Because they're not the patient's own cells, there's also a chance that they will be eliminated by the patient's immune system much faster. And in order to circumvent both of these problems, giving allogeneic CAR T cell requires a more intense lymphodepletion than what's normally given for autologous cells, and that in turn causes more profound suppression of the immune system and may lead to a higher rate of infections. So definitely a lot of advantages for these allogeneic CAR T cells, but also some challenges. So these are the results that were presented at ASH of the universal trial. The patients received ALLO-715, which is the allogeneic anti-BCMA CAR T cell. And in addition, more lymphodepletion with a drug that's called ALLO-647, which is an anti-CD52 agent that reduces the patient's own T cells. You'll see here on the left side that the overall response rate was fairly good, 60%, so maybe not quite as high as what we're observing with the autologous CAR T cell product, but it's difficult to do cross-trial comparisons because the population of patients that's treated in each trial may be slightly different in terms of how many regimens they have received previously and how refractory they are. But what was definitely also really encouraging is that no graft versus host disease was observed in the 30 patients who've been treated on this trial so far. And we have the study open at Stanford, and we have in our own patients not observed any GVHD, so that's definitely encouraging. So what about other CAR T cell toxicities that we need to be aware of? There are a couple of toxicities that are very specific to this type of immune therapy, and the first one is cytokine release syndrome. So as the cells are being infused and they start targeting the myeloma cells and they expand, they initiate an inflammatory response in the body that can lead to the cytokine release syndrome. And it usually begins with fever and rather unspecific symptoms like malaise, but it can impact pretty much all organ systems. So milder cases will present as more like a flu-like illness, but more intensive or more significant cytokine release syndrome can affect all organ systems with the symptoms that are described here on the right side, and can affect the cardiovascular, the pulmonary system, that can affect the kidneys and the liver. So we have to be very careful and very mindful of this toxicity. There's a grading system for cytokine release syndrome that's mostly based on the presence of fever, the presence of tachycardia or hypotension, and hypoxia. Those are the main things to look out for, in addition to the other organ systems like the liver and the kidneys, of course. The other toxicity that's very specific to these immune therapies is something that's called ICANS, or immune effector cell-associated neurotoxicity syndrome. This is a toxic encephalopathy that can present with just mild headaches, but it can also cause more significant symptoms like confusion or delirium. Expressive aphasia is not uncommon. Seizures are rare, and we do give all patients seizure prophylaxis, and very rarely will observe cerebral edema. This can occur in the presence or absence of systemic CRS, so it's not necessarily associated. And here on the right side is just an example of an assessment that's done for the patients every day, where we ask them to write down a sentence, and you'll see that the first couple of days the patient is doing just fine, but then in the middle of the treatment, after about 5 days or so, they're having trouble, writing down the sentence. This idea of grading ICANS has evolved into something that's called the ICE score. And so we ask the patients every day, and check whether they're oriented to time and place, whether they're able to name objects, if they can follow commands, write down a sentence, and whether they are able to count backwards from 100 by tens. And based on the score, then we assign them the grading of an ICANN if it's present. So this is a very very useful system that's easy to use and makes it easier to compare the severity of the neurotoxicity across multiple trials and multiple CAR T-cell products. The timing of the toxicity is also really important. CRS tends to occur a little bit earlier than the neurotoxicity, as early as sometimes just a day after the cells are given. It is associated with disease burden. So as the disease burden goes down, CRS usually subsides certainly in a matter of weeks. While neurotoxicity is an event that can also happen later on. So it's important to stay vigilant and monitor patients for this. In terms of treatment, CRS can be treated with steroids. We were initially reluctant to use steroids because they also kill off the CAR T-cell product, or at least can reduce the presence of the CAR T-cells. But that's been shown to be actually less of a problem than we initially anticipated. And then there is a drug that's called tocilizumab that inhibits IL-6, which is an inflammatory mediator, and that's quite helpful in treating CRS. Tocilizumab is less helpful for neurotoxicity. There we're really mostly relying on steroids. The other thing that's really important to keep in mind is that as a result of the lymphodepletion chemotherapy and the CAR T-cell product itself and the inflammation, patients will oftentimes have prolonged cytopenias. Prolonged neutropenia is not uncommon. Prolonged thrombocytopenia has to be watched for. And with the neutropenia and the lymphopenia comes a risk for infection. So we give an infection prophylaxis for usually around 4 weeks or so until counts start to recover. But monitoring for infections is definitely one, and cytopenias is one other major part of the CAR T-cell toxicity. So here are the rates of this toxicity observed over the various trials. So for ide-cel specifically, at the highest dose of 450 million cells, CRS is observed in almost every patient. The median time of onset is just 1 day, but it ranges from 1 to 23 days, and the median duration is about 7 days. The most common manifestation is usually fever. Almost everybody gets a fever. In not quite half of the patients, we observe hypotension and then also tachycardia. In terms of neurotoxicity, about 20% of patients had some degree of neurotoxicity with the highest dose of ide-cel. The higher grades of neurotoxicity is fortunately uncommon. In terms of prolonged cytopenias, about 40% of patients had prolonged grade 3 or 4 neutropenia, and 50% had prolonged grade 3 or 4 thrombocytopenia. One other thing that I just wanted to mention, which is not necessarily a form of toxicity, but definitely of concern, is mechanisms of resistance to CAR T cell therapy. They can be either T cell dependent, so there's something going on with the product. So either the CAR T cell receptor is not binding well to the target, or the cells are not really being activated the way we expect, or they just don't expand. Or sometimes they do expand, but they don't last very, very long, which is called T cell exhaustion. There are also myeloma cell dependent mechanisms of resistance, and that's mostly a phenomenon that's called antigen escape, which means essentially that the patient's myeloma cells stop expressing the BCMA target, or whichever one the CAR T cell target is, but in this case, BCMA. It may either completely stop expressing the target, or it may express a variant of the target that the CAR T cell receptor can no longer bind to. So these are definitely challenging situations for us, and there's a lot of research being done to overcome and address these resistance mechanisms. So I think this, summarizing everything, it raises the question, when should we consider CAR T cell therapy? There is an FDA-approved agent, which is ide-cel, that's approved for patients with more than 4 prior lines of therapy, including a proteasome inhibitor, an immunomodulatory agent, and an anti-CD38 antibody. The other thing that's important is to think about the kinetics of the disease progression. Right now, the product has to be manufactured from the patient's own cells, so we have to make sure that the patient is able to wait and remain stable until the T cells are actually manufactured, which can take several weeks. And we have to see if the patient is able to tolerate any bridging therapy in the meantime, or if there is any available that can at least keep the myeloma at bay while we're waiting for the CAR T cells to be manufactured. If a lot of steroids or Cytoxan has been given prior to collection, then that raises concerns about being able to collect sufficient number of T cells, because agents like Cytoxan or like dexamethasone actually kill off a lot of T cells. And then the other things that we look out for are comorbidities, any pre-existing cardiac or pulmonary disease or neurologic dysfunction or active infections does put patients at higher risk with this therapy. And so we need to think very carefully about whether this really is then in the patient's best interest and whether it's safe. So just to summarize everything, definitely immunotherapy, including CAR T cell therapy, is taking center stage in myeloma. And there's no doubt that CAR T cells are highly active. We do have to be aware of their side effect profile, which includes CRS and neurotoxicity and prolonged cytopenias. But these side effects, we've learned a lot about them in the past, and I think they've become more and more manageable. And then lastly, next generation CAR T cell products are being designed and worked on to overcome the issues that we have with the current products and to overcome potential mechanisms of resistance. And with that, I want to thank you for your attention and just introduce our Stanford Myeloma and amyloids and our team, and thank them for working with me every day. Thank you.